On behalf of Crosstex, a Cantel medical company, I welcome you to our webinar, Nitrous Oxide Oxygen Sedation, Steps for Safety and Compliance. My name is Leanne Kiefer, and I'm the Director of Clinical Services and Education for Crosstex. Nitrous oxide oxygen sedation has a very strong safety record, and it is an effective means of managing pain and anxiety for dental patients. This course will address and clarify various safety and administration concerns for both the patient and the clinician. Nitrous oxide oxygen sedation has had an amazing safety record since its discovery over 175 years ago, and it's withstood the test of time. We see that in dentistry, approximately 89% of all pediatric dentists use nitrous in their practice. And on a general dentist side, approximately 58%, but we see that percentage as increasing over the past few years. We talked about the relative safety and efficacy. One of the important points to remember is that nitrous is not metabolized through the organs. It's actually just excreted through the respiratory system, and it's virtually eliminated from the body when the nitrous gas is discontinued. It's meant to be used as a mild analgesic in a form of sedation, and sometimes you'll hear people talk about an anxiolytic, and it just means it gives that feeling of well-being to the patient. While it is effective for pain and anxiety management, it does not replace local anesthesia, but it can help to make the local anesthesia delivery much easier for both the patient and the clinician as well. In regard to guidelines, there are no definitive OSHA regulations. And remember, OSHA is both federal and regulatory, but they don't have any regulations or standards on nitrous oxide or gases other than the standards that regulate inspections, safety, and handling of compressed gases. The National Institute for Occupational Safety and Health, which is NIOSH, in 1977, NIOSH gave a recommended exposure limit. Sometimes you'll see that referred to with the acronym REL, recommended exposure limit, for nitrous at 25 parts per million as part of a time-weighted average. And this REL is intended to prevent decreases in mental performance, to ensure audio-visual ability, and to maintain dexterity during exposures. Currently, an REL to prevent adverse reproductive effects cannot be established until more data is available. It's important to note when I mentioned 25 parts per million, it was determined that this level was achievable in an operating room setting where the patient is going to be intubated with an endotracheal tube and the use of a full face mask for delivery of the gas. However, this is not attainable in ambulatory settings like a dental practice. So NIOSH chose 50 parts per million as the maximum exposure for personnel in a dental setting. And this standard remains to date. I also want to mention another group that validated the 50 parts per million, and this is the American Conference of Governmental Industrial Hygienists. The acronym is ACGIH, and they set the threshold value limit at 50 parts per million. And it was determined that index states, and I quote, control to this level should prevent embryo fetal toxicity in humans and other adverse health effects in exposed personnel. So the ADA also supports the use of the 50 parts per million. We know that exposure to ambient or trace or waste levels of nitrous oxide may present an occupational hazard for dental health care personnel, it is our responsibility to take all the necessary precautions to minimize those risk factors. And when we look at some of the studies, sometimes people get confused by how the study was done or what the study was interpreting. Some of the early research actually goes back to the late 1960s with a study done on Russian anesthesiologists. And we want to remember that when the studies are looking at anesthesiologists in an operatory setting, it's very different compared to the dental setting because we have minimal periods of time that we're using the nitrous oxide, and we're using it at a much lower percentage concentration. The Cohen studies in the 70s, and then finally the most recent one that he did in the 80s, they looked at 50,000 dentists and dental assistants, and they wanted to look at how they were, the exposure to trace anesthetics, and what the impact was on general health issues and reproductive difficulty. Now, there were a couple flaws with this particular study. First of all, the trace or waste gases, the concentration was not evaluated, wasn't measured in this study. And the data that was collected and reported was via a survey, so the information was coming from memory recall from the clinicians. So it's retrospective in nature, and there was also the biases that happened as a result of the interpretation. We also look at the Bruce study. This was done in the mid-70s, 1974 to be exact. And they wanted to know how nitrous affected the cognition and psychomotor skills to varying concentrations of nitrous, and especially how it affected the audio-visual impairment. The problem with the study is when they tried to duplicate the results, they couldn't be duplicated. And eventually, Bruce and researchers actually retracted their conclusions, which was an indication that the results were not based on biological factors. What we need to take from all this is we know there is a potential risk, and in order to gain safer work practices, we have to follow the recommendations, and that includes things like the use of an effective scavenger system. We have recommendations for ventilation and for air exchanges. Obviously, there have been a number of improvements in equipment upgrades over the years. We also have a variety of methods that we can monitor or trace the ambient gas levels. And then also there's personal monitoring badges or dosimeters that are available, and we're going to go into each of these in a little bit more detail. So let's talk about the nitrous exposure and the impact on reproductive health. Without going into too much detail, what happens with the nitrous is that it actually oxidizes the cobalt form of vitamin B12. And when that happens, it inactivates something called methionine. And methionine is part of an enzyme that the body needs for several parts of development. It's required to make normal red blood cells, white blood cells. It helps to repair tissues and cells. And most importantly, it's involved in the creation of DNA. And the research that we're seeing has linked chronic exposures to high levels of nitrous. Remember, we're using low levels of nitrous in dentistry, and we're using it for shorter periods of time. The research is on high levels, so we need to keep that sort of in perspective. The important thing to remember for clinicians who are pregnant or ready to become pregnant, the first trimester is very, very critical. And so a great action to take is to know what the exposure levels are in your practice before. So actually get a baseline of what the exposure levels are to nitrous in your practice. And make sure that you're using the variety of scavenging methods that we'll be outlining. It's also important that the clinician would have a medical consult with their physician or their OB. And it's been mentioned in literature that should a female opt to avoid the office setting and nitrous oxide exposure for the first trimester, that would be a choice. Now, there are limitations, again, to the research and some of the results that have been reported. And part of it, most of them will include like maternal age and smoking history as part of the cofactors. But many didn't include alcohol consumption or history of previous miscarriage or the number of times a person has been pregnant and or number of times delivered before 24 weeks. And all those cofactors need to be considered. The last part that I would mention is many of the studies, the historical studies, were done prior to the scavenging systems being widely used and considered to be best practice. Also, none of those historical studies included ambient gas level samples. So those are just some things, to think about. So when we talk about exposure to trace elements or ambient gas leaks, it can occur from the delivery system itself. There's also things that the patient can do that might contribute to leaks, but let's focus on the system itself. So it may result from leaks in the equipment, in particular the rubber and the plastic components where the connections are. They may be degraded by the gases over time, as well as if there's any repeated sterilization of the equipment. And the arrows that you see here are indicating all the spots that we need to check on a regular basis to make sure that we're not experiencing any leaks in the system. So the sources would include the connection at the canisters. You notice we call them gas canisters, not tanks. The wall connectors, if you are using a central type system, the hoses that connect to the delivery machine, and then also we can see some low pressure leaks that occur from loose connections. So you want to make sure that the connections are nice and tight. We also can see if the threaded connections are not aligned up appropriately. Also, look at your seals, gaskets, O-rings, your rubber goods to make sure that we're not getting any leakage from those areas as well. And we're going to talk about how do you test. It's more than just visual. When we talk about waste anesthetic gases, or the acronym WAG, NIOSH, in the publication you see listed, the direct quote was, increasing the awareness about adverse health effects of WAG, describing how workers are exposed to WAG, recommending work practices to reduce these exposures, and identifying methods to minimize leakage of WAG into the work environment. And it has been proven that this leads to improvement there have been improvements in vacuum lines, in the scavenging equipment, and newer delivery systems as well. So we are going to go over in a little bit of detail when we talk about reduction of ambient nitrous. We need to provide a ventilation that provides good room air mixing. And in addition, we may be using an auxiliary exhaust ventilation. This would be something that might be placed near the patient's mouth within, say, 6 to 10 inches. And it would be an auxiliary in addition to the vacuum scavenging that happens through the mask and the tubing. There are limitations to using the auxiliary exhaust because it can, it's in proximity to the patient. It's going to have some noise issues. Sometimes the installation that's required and maintenance cost can be a deterrent. It's also important that if you're using one of these auxiliary, that it not be between the clinician and the patient, because you don't want the air to be drawn up in front of the clinician's face directly. As far as the scavenging system that's part of your high volume evacuation system, this is going to be removing, when you're using it with an HVE tip, obviously it's going to remove fluid and debris from the patient's mouth, but when it's connected to the scavenging system, it's going to take away the waste air, the waste gas from the patient is expelling through their nose, and move it away to the, vented to the outside of the building. When it is vented to the outside of the building, it needs to be away from fresh air inlets, and because you don't want to be bringing that back into the office. You also want to make sure, besides fresh air inlets, it should be vented away from windows or walkways. And you don't want it to be vented back into a recirculating ventilation system within the office. If the concentrations, when you're doing your evaluation, you're trying to get your baseline, if your concentrations are above the 50 ppm in work areas, you want to increase the airflow into the room or increase the percentage of the outside air to allow for more air mixing, and it further dilutes any of the waste gas. So it's important to maintain a balanced air supply and exhaust system so that nitrous doesn't contaminate other areas. If after doing this, you're still above the ppm, that's when you would use or may want to consider an auxiliary or supplemental ventilation with a scavenging system. So, trace contaminations in the ambient air, and how do we check the equipment? You can do something that's very simple. It's a soapy water test that you would be applying a prudent amount of water on all the connections, on all the areas where there could be a leak. And if you start seeing bubbles occur, you will know that you do have a leak. I think it's important to mention that scavenging equipment is considered standard of care, and to be using a nitrous oxide oxygen delivery system without scavenging equipment is not ethical. We are required to use it. Again, you want to get baseline values in your practice, and then you want to do comparisons on a periodic basis to make sure that you're still following within the guidelines. NIOSH and the ADA, as well as the manufacturers of equipment, recommend that we do a semi-annual, at minimum, equipment verification. And then you want to have your flow meters evaluated, possibly reconditioned every 2 years maximum. So how do we monitor our exposure trace levels? We have a couple of options. We can use personal dosimetry badges that are to be worn during administration of nitrous oxide, and it collects, and then the badges need to be sent in to be read. So remember your cost factor, because there's going to be a cost factor to purchase the badge, and there may be a separate cost factor to have it read. We also are able to use the handheld monitoring systems that can read trace levels. And the last and the most sophisticated method is the infrared spectrophotometer. And while the purchase cost is prohibitive for our dental practice, these can easily be rented, or you can contract with a professional to come into your office to evaluate. When we spoke of the variety of safe practices that we have to manage trace gas, we look at it in terms of hierarchy of controls. And we're going to basically, it goes from the blue, the top at the elimination, that's the most effective, down to the lesser effective. But where we're going to focus our time is we're going to be talking about engineering controls and administrative controls in particular. So engineering controls, basically what that does is it isolates the person from the hazard. It's designed to remove the hazard at the very source before it comes into contact with a clinician. And this is extremely highly effective. It's typical that it's going to be independent of something that the worker themselves do. The cost of engineering controls can be a little bit higher, but over the long term, the costs provide, it may be a lower cost because of the savings that it provides. Administrative controls are ways that we change the way that people work. And then last but not least, PPE or work practice are things that protect the worker themselves. So engineering controls, a little bit more detail. Using a patient nasal mask that has scavenging hoses attached to capture the expressed nitrous from the patient. We talked about using local exhaust ventilation near the patient's mouth if you're having trouble controlling your baseline at 50 ppm. It's also important that we are checking the delivery system for leaks, as we talked about the soapy water. Remember, do not start the flow of the nitrous until the mask has already been applied to the patient's nose, because you don't want any gas in the ambient room before it's put onto the patient. And obviously, best practice is turning off the nitrous at the end of the procedure and allowing the patient to breathe oxygen. This flushes the patient's body of nitrous as well as the system, and it helps with the recovery time for the patient having straight oxygen. You need to have your personal and environmental monitoring practice, and you want to look at essentially the past 12 months if you're going to be doing monitoring exposure to get the baseline. So, administrative controls. Administrative controls are things, training to make sure that all of the workers are aware of how the equipment should be used, what are the standard scavenging procedures. We need to have a written plan. So the employer's standard operating procedure. And this written plan, you need to consider what your individual unit manufacturer's recommendations are for the maintenance and repair of your particular unit. You also want to have a written program of what your routine inspection is, and then how you do regular maintenance of the equipment in order to reduce any type of leaks so that you have best performance of your scavenging equipment and your room ventilation. I think it's also important to say that preventive maintenance needs to be performed by trained professionals according to manufacturer's recommendations and at the intervals determined by the IFU and on frequency of use. Preventive maintenance is going to include inspection, testing, cleaning, lubrication, and adjustment of various components. And worn or damaged parts should be repaired or replaced. And again, we need to really watch like gaskets and valves and O-rings because they do need to be replaced on a routine basis. Last but not least, documentation in this plan. You should also keep any type of maintenance or service records that indicates what was the nature and the date of the work, as well as the name of the trained service tech that performed the repair or the maintenance. As far as work practices, the nasal mask needs to be appropriately sized because it should have a snug, contoured fit that's comfortable for the patient, but that seals well around the periphery so that you do not have leakage of gas from a poorly fitting mask. The other thing I would mention is if you look at the picture that you see on the screen, some of the newer mask designs have both an inner and then a slightly larger outer mask component. And the inner mask actually has the two hoses attached to it that supply anesthetic to the gas, and then it also then helps to scavenge the gas to the evacuation system. What they're seeing with this double mask sort of configuration is that it's going to have a better rate of reduction of trace gas, to the point one study showed that it reduced staph exposure to when 50% nitrous was used very, very well with children. So having it sort of catches the extra and it lets it be evacuated out. Now, we talked about not starting the nitrous gas before it was applied to the patient. We also want to use the appropriate titration or dosage, and that has to be determined by the clinician monitoring the patient. And on average, it's going to be somewhere between 30 and 50% on average of nitrous delivery. You want to make sure that when you're using a patient demand type of system, that it has a reservoir bag or a breathing bag. Watching that breathing bag is also going to tell you how the flow is going. If the bag should never be more than about 2/3 full. If the bag looks like it's overinflated like a balloon, there's too much gas going, and the patient's tidal volume, their breathing isn't using all the gas, so it's filling up in this breathing bag. So you need to turn the gases down, the flow of the gases down. On the other hand, if that reservoir bag stays pretty flat, your patient may report, they may say things like they feel like they can't breathe. They feel like they're suffocating because they're not getting enough flow, and so you need to increase the flow to the patient. So the breathing bag can tell us a lot of different things. We've talked about minimizing some of the occupational exposure and making sure that everybody's been trained. And if we have to do any type of surveillance to watch to make sure that we're not seeing any signs, things like somebody saying they have a headache, they feel nauseous, could be some signs that there is an overexposure. It's also very important that we watch how we handle the cylinders themselves. You want to make sure that both the full and the empty cylinders, they should be stored separately, and they need to have the appropriate signage to know which is which. We have to be very careful not to allow any type of grease or oil to come in contact with the cylinders or the valves because they are compressed gas. We need to have our storage areas identified with signage, just like the example of the red sign that you see on the slide. The containers or the cylinders should be in a cool, dry, well-ventilated, and fire-resistant location. And this is according to code. They also need to be secured at all times, whether they're full or they're empty, to prevent them from tipping, falling, or rolling. So you could use something like a strap or chain or a wall bracket or other type of fixed surface, or they can be kept in a specific cylinder stand. Be sure if they are stored somewhere outdoors, like in an enclosure outdoors, they have to be protected from a damp ground or floor, because otherwise the cylinders themselves can corrode. Also, never lift a cylinder by the valve or by the protector cap. That's just the safety. And we should always use a cylinder wrench or another tight-fitting wrench to tighten the regulator nut and the hose connections. It's not something that we do by hand. We need to use a wrench. And anytime you're going to open a cylinder valve, they should always be opened slowly. So what is the recommended equipment maintenance? There's routine and there's preventive. So routine is, we've said, looking at worn parts, crack holes, and tears. By the way, with your breathing bag, make sure that when you look at it, you're not just looking at it in its flat, empty state. Open up, the sides of it so that you can see, especially where the creases are, because this is sometimes where it will become worn or get tears or punctures. So make sure that you're looking at it both when it's not inflated as well as when it is inflated. And again, it's open water test. Test the pressure leaks, and we're going to talk a little bit more about surface disinfection of the equipment in detail a little bit later. We said the flow meter at maximum or at minimum is every 2 years that we need to have it verified, and then your annual leak and your leak testing. So what are the built-in safety features that are part of the system itself? Many of them come with various audible alarms or visual alarms that can alert you that something is wrong with the system. We also have color coding of the cylinders as well as the hoses. The color for oxygen is always green, and the color for nitrous is always blue. The DISS, or the Diameter Index Safety System, is something I'm going to talk about, and I'll show it to you so you actually can see it. It's what's going to help prevent it from having an incorrect connection between the hose and the cylinder. There are emergency air inlet valves that are on the systems. There are locks to be able to put on the system so they cannot be used inappropriately by others. There is an O2, an oxygen fail-safe system. And this one is really important because our systems, the newer systems, are set to maintain a 30% oxygen level. Because ambient air is about 21% oxygen, so 30% oxygen, and that means that the maximum that can be delivered, maximum, is 70% nitrous. And remember, I stated that 30 to 50% nitrous is what tends to be average. If something would happen that you would run out of oxygen, the system itself shuts down so that pure nitrous cannot be delivered if there's not adequate levels of oxygen that can be mixed. So that's the fail-safe system. It can't function without oxygen. There is an O2 flush button, and then the PIN index safety system, again, I'm going to show that to you, is with our portable systems, and it's the way that the smaller canister is going to attach to the metal stand or the yoke to make sure that we're connecting the right canister to go to the right hose, connection hosing. We have quick connect features, and we've talked a little bit about the reservoir bag already. So on our portable system, what you see here is there's the metal stand or the yoke. Usually it's on wheels, and the canisters are going to attach directly to that system. You'll see the breathing bag is there. The DISS system is what you see in the middle, and if you can actually visualize the oxygen, the diameter of that is larger than the diameter of, I'm sorry, I said that backwards. Let me start again. The diameter on the nitrous blue hose is larger than the diameter on the oxygen green hose. And so it's going to be connected into the valves to the canisters that are appropriate. And I'm just showing you the size of canisters that are available. I happen to have the oxygen canisters up here. These could be nitrous canisters as well. The E-size canister is what's used with the portable system, and the G and H cylinders are what would be used in a central system that's built in. This is an example of a central system with the cylinders secured, and those cylinders then are attached to a manifold. The manifold is going to help to deliver the gas to the various treatment rooms, and then there's going to be a flow meter like you see on the bottom that will show you what the flow and the percentages of the gases that are being used. You always want to make sure that you're having professional installation for all sedation equipment, because we need to ensure that the current codes and specifications are met. So, the pin index system you see on the cylinders, and then the DISS hoses that we talked about. And so the hoses will only fit into the specific pin index diameter that it's meant to accommodate. And so this prevents an incorrect cylinder attachment and delivery of wrong gases. I added this slide just as a precautionary measure to say that, yes, while we can deliver oxygen if needed through our delivery system, it is considered best practice in your emergency equipment kit to have a BVM, which is a bag valve mask ventilation piece of equipment. This is a manual resuscitator. Some of you may have heard it referred to as an AMBU bag. AMBU is excuse me, is a brand name. It is a BVM is the appropriate term. What we want to remember is that if we need to do administration of a high flow oxygen for some reason, it is recommended that it's a 2-person delivery. And the acronym JAWS, J-A-W-S, can be helpful because you want to make sure that you're moving the jaw down with the thumbs and make sure that the airway is clear, both the oral and the nasal is clear. You're going to be working in combination, best to have an assistant who's going to actually be doing the squeezing if that is possible. And the thing that most people do incorrectly is they squeeze it too fast and too shallow. Remember, we breathe at 12 to 15 respirations a minute. And so what's recommended with these is that you do a slow, small squeeze. And it should actually be with 2 hands with the thumbs facing down on top of the bag. And then doing that squeeze about over 1 to 2 seconds at about 12 squeezes per minute. And you want to use this lower pressure. You don't want to do the quick, fast squeeze. So having a BVM is a helpful piece of equipment. When we talk about reprocessing or disinfecting and or sterilization of different parts of our delivery system, the vast majority of offices are using a disposable single-use patient nasal mask because to clean them and then reprocess them, it's very time-consuming. So single-use disposable. And it's helpful for the piece of equipment, if you're going to be doing a portable system, draping that portable system, the yoke unit with the flow meter, with a clear single-use disposable bag. You can get very large bags. I've heard some off-label use of dry cleaning bags being used for this regard, but that helps to, it reduces the amount of surface area cleaning at the end of an appointment. When you do use some type of a surface disinfectant, you want to be sure that it is an approved medical grade surface disinfectant. And some of the manufacturers will actually give you specific recommendations on different disinfectants that have been tried on their particular product. Remember that the conduction tubing, the hosing, it's exposed to both the patient and the patient environment. However, no studies have verified any disease transmission between patients through the conduction tubing. Now, when I'm talking about this conduction tubing, a lot of times it's going to be the corrugated type of tubing, and most of the time it can withstand being steam sterilized. Again, you have to read your manufacturer's instructions for use. Now, sometimes there are connections or valves that are on the tubing that need to be removed because they're plastic and they cannot withstand, they're not heat tolerant. So certain pieces may need to be removed if you're choosing to steam sterilize the connection tubing. It's also, again, remember, we never want to have any type of oil or grease on any part of the system because of the flame conductivity of the gases. All right, best practices overall. The AAPD, the American Academy of Pediatric Dentistry, and the ADA both have lists, and this is inclusive, of what are considered to be standard of care. And so we want to make sure that we've trained our dental personnel on minimizing occupational exposures. We want to make sure that we're using scavenging systems. The scavenging systems need to be running at 45 liters per minute, and that's going to be measured by a calibrated flow device. Okay, so that's that's sort of our target. We want to use the scavenging systems that are part of the patient's nasal hood and the evacuation system. We want to make sure that it's vented to the outside of the building. If you have a window in your treatment room, it may be an option for you also to open or vent the window in your operatory if that's a possibility. Sometimes some of these standards are a little bit more difficult in some of the high-rise type of office buildings, so it's something that you have to look at and evaluate individually. You want to make sure to consider your patient selection. What are the indications and contraindications? And we are just going to do a quick 2-slide review of contraindications just to refresh your memory. Making sure that your mask is appropriately sized for the patient. We're always going to monitor the patient during delivery to make sure that the titration, the dosage, and the flow, the volume, is going to be at the minimal effective dose. And because we don't want to give them more than they need, it would waste gas. We also need to encourage our patients is to limit talking, because when they're talking and they're breathing nitrous through their nose, they will be expelling gas from chatting with us. So it's helpful to determine some communication signs that if they want to, that you give them that they can do, lifting a finger. How can they signal you if they need to communicate something? But we really want to limit talking. That's one of the greatest areas of contribution to trace gas, is patients talking during the procedure. I want to go back a slide just for a second. When we finish the procedure, it is important to make sure that the patient is getting 100% oxygen for at least 5 minutes before removing the mask. And it's not just a matter of saying, hey, do you feel okay? We need to evaluate the patient to see how they are responding, that they're recovering from the nitrous oxide. Again, it also helps to eliminate any of the residual nitrous from the patient's respiratory system, as well as any residual gas that is in the connections and tubing. So, ethical and legal considerations. We must take a health history at the beginning of each and every appointment, and it should be signed and dated. We need to conduct a comprehensive pre-operative evaluation of the patient. There are survey tools that are available. You can actually look them up online, and you can design it to meet your individual practice needs. We have to make sure that the sedation methods that we're using are going to be addressing what our patient's individual needs they're presenting with. We must have written informed consent. Must have. We cannot proceed without written informed consent. If the patient is a minor under the age of 18, or if they are mentally challenged, then legally they have to have either a parent or a legal guardian that would sign for the informed consent. Now, it is recommended that you have an informed consent signed each time nitrous is used. It's not a one-time and done. You need to have informed consent each and every time. We want to make sure that we're monitoring the patient continuously. They should never be left alone when they are on nitrous oxide oxygen sedation. We would be taking pre-treatment sedation vitals. So you want to check their respiration, you want to check their pulse, and you want to check their blood pressure. And all that should be documented pre-delivery of the sedation. We have to make sure that if we do have high-risk patients that they're being treated in an appropriate setting, and that everybody who's going to be involved with either administration or monitoring, it's in accordance with what is permitted by each state. So what are the indications for use? AAPD is, indications would be to help reduce pain, alleviate anxiety, suppressing gag reflexes. If we have a lengthy dental procedure, this can help the patient be more comfortable, more cooperative, and also their sense of time is way shorter when they're on nitrous oxide sedation, oxygen sedation, and they may have very little memory of the dental procedure afterwards. So it can make a lengthy procedure a lot more tolerable. When we do this, we get better treatment outcomes with the relaxed patient. As clinicians, we can concentrate on the treatment that we're providing without the challenge of having to deal with anxious patient management. These are the two slides that I said we would talk about with contraindications. And the list here is we're talking about what they call relative contraindications. And that means that caution should be used when these conditions are present. Now, obviously, you know, if you flip down to the third bullet point, pregnancy, remember, never, ever, ever in the first trimester, and always consult with the patient's physician or OB on this issue. You also see things like the blocked middle ear or recent ocular or eye surgery. And the reason for this is nitrates as a gas is very soluble, and it can enter open spaces very rapidly. And what will happen is that it will fill the space, and it can do things like it could actually cause the eardrum to burst. So when you have patients that have like an obstructed bowel, the part of the GI tract may be empty because of the bowel obstruction, or they've had middle ear issues. They could have a blocked eustachian tube. If they have had ocular surgery, and I've got to think, if they've had, there's a specific treatment that's used. I'm sorry, I'm drawing a blank on but ocular surgery, you don't want them to be using nitrous. If they've had LASIK surgery, retinal detachment, that type of thing. Now, the other one is going to be contradictions that are absolute. And when a contradiction is absolute, that means that this could be a life-threatening situation. And so we should not be using nitrous during these times or during these issues with patient. Again, notice the last two, patient refusal, or if you do not have a written informed consent, you would not deliver nitrous. What needs to be on your informed consent? Patients need to understand what the intent and the purpose of using this drug for the procedure is. They need to know what the expectations are during the sedation procedure. They need to know about any risks that are associated. Remember when we talked about we don't want them to chat, we want to give them communication techniques that they can use for their safety and comfort. They need to know what the expectations if nitrous oxide oxygen sedation is not used or they decline it. Are there any other options for alternative sedation methods? What is the cost? They have to have the opportunity to ask questions. It is recommended that you have a separate consent form for nitrous oxide oxygen sedation, and the patient's signature or the parent or legal guardian should be dated before each sedation experience. And we talked about the minor or the mentally challenged patient. When you have finished with treating the patient and you have delivered the O2 and now you are going to do your documentation in your patient chart, we should be listing what the indications for use for that particular patient were, that you reviewed the medical history and there was no contraindications, that you've taken the pre-op and post-op. So again, post-op, respiration, blood pressure, and pulse rate. And they should be within they should be within 10% of what the previous preoperative readings were. It is important to record the patient's tidal volume. In other words, how much they're going to be, what's your liter per minute, because that's going to stay pretty constant from time to time. You don't want to say, well, if we use this certain peak concentration this time, that we're going to start there next time. Remember, each patient's an individual, each time is different, and while their tidal volume, their lung capacity, will be standard, the concentrations can vary from time to time. You want to note the time the anesthesia began and ended. You don't just want to put 40 minutes. You actually want to put clock time written down with AM or PM. Note how much postoperative time in minutes for the patient to recover. Sometimes you want to look at the patient and you can determine how they respond visually, what their coordination is like before you would be able to send them home. And there is a Vancouver survey that actually has those 3 main parts. There are 12 questions, and that can help you in determining, is the patient in fact ready to be dismissed? Also, the patient is to be dismissed legally and ethically by the person who was administering the nitrous and oxygen sedation, by the person administering. If you need to have a medical consult or you had a medical consult with a physician or a healthcare provider, those should be noted on the patient chart, as well as any adverse events, reactions, or patient complaints on the documentation. And I've given you a sample. There are a number of sedation records or informed consent records available. The AAPD has a sedation record that is extremely complete and is very useful. And you can find that by going online. So again, you want to make sure your patients are alert and oriented, that the vital signs are stable and within acceptable limits. Remember, each patient is different, and the clinician is responsible for dismissing the patient. All right, with that, I am going to stop, and we're going to go ahead and take any questions that you might have. I see we have a few. Just a moment. Okay, there's a question that's asking about high-level dosages. High-level dosages, we said that the average is that the patient is between 30 and 50% is considered to be a low-level dose. We very rarely in dentistry would use the maximum 70% high-level dose that can be. 30 to 50% is considered within acceptable dosage limits. There was a question about the cost of the handheld electronic nitrous meters. I want to say, to the best of my recollection, there are some that are available around the $300 range, and they would go up from there. You need to make sure that it is going to be able to measure trace levels of nitrous for the gas. So that has to be specifically listed. Okay. One of the dentists who's with us tonight has noticed that some of the corrugated nitrous hoses are difficult to wipe down with disinfecting wipes. It feels like the ridges on the corrugated tubing grip the material that the wipes are made of. And the dentist is wondering if anybody else has experienced this. I can't say that I have heard that specifically from anybody else. One thing that might be helpful is, instead of wiping the tubing like in an up and down the length of the tubing, it might be easier to try and wrap the wipe in your hand around the tubing and move it in a back and forth wrist motion instead of an up and down the length of the tubing. There was a question about the relative contraindication for a patient with ADHD. It's been noted that sometimes patients with ADHD, the nitrous will have an opposite effect. It will not have the calming effect. It will exacerbate the hyperactivity. So that's one of the things you have to determine with your individual patient. Again, relative means based on each individual patient needs. Multiple sclerosis, contraindication, and again, this is not meant to go into great detail, but it has to do with suppressing the natural instinct or drive to breathe. That nitrous can complicate that with multiple sclerosis. There's another question about administering in the nitrous in the third trimester. There was some studies that look at the O2 levels in the last trimester, that might be considered a relative complication. And you need to look at the individual patient. If you can delay treatment and not do it in the third trimester, but are talking with the patient's OB to see about their O2 saturation levels in the last trimester would be the only other issue. And with that, I think we have gone through. Just a minute. Nope, hang on. Okay, my dentist who had an issue, the tubes aren't corrugated, they are smooth. This was the one who was asking about that it catches. The only other thing that I can think of, this is sort of an anecdotal solution. Make sure that the wipes are in fact saturated enough. If the wipes have begun to dry out, they will catch against the tubing. So just make sure that they're fully saturated. Sometimes turning your wipe containers upside down at night helps to redistribute the liquid and can make it a little bit easier. All right, and with that, on behalf of Crosstex, I thank you very much for your time this evening. I would also encourage you, we have 4 other nitrous programs available on demand, and 3 of them were done with an anesthesiologist. And so if you'd like some more detailed information, those are available for you at Viva Learning or crosstexlearning.com. Thank you for your time this evening.